Hello everyone. My name is Jake Mantuffel. I'm a EM physician at Henry Ford Hospital in Detroit. I'm also boarded in addiction medicine, and I'm going to be co-presenting today with my colleague on precipitated withdrawal. And I'll just take a minute to I'll introduce Dr. Nick Rademacher, and I'll let him introduce himself as well.
Thanks, Jake. I'm Nick Rademacher. I'm also an emergency physician with an interest in the treatment of opioid use disorder. I'm also board certified in addiction medicine, and I'm excited to be here today.
Excellent. Yep. And our topic for today is precipitated withdrawal. And we're going to focus on this kind of exclusively today because aside from a few other things that we'll mention, I think fear of precipitated withdrawal is one of the biggest barriers to treating patients with opioid use disorder with some of the medications available. So we will hope to allay some of those fears and dive in here. In full disclosure, we are both technical assistants for the Community Foundation for Southeast Michigan. However, we do not receive any additional financial benefit for the prescription of medications or the treatment of any patients with opioid use disorder. And this little graph here shows, I believe, the emergency departments that the Community Foundation for Southeast Michigan has reached via grant to help implement ED MOUD programs. So the learning objectives that we'll cover today are to understand the pharmacology of precipitated withdrawal and to understand why you're seeing what you see when you see it, and to know when fentanyl and methadone puts patients at increased risk for precipitated withdrawal, and to gain comfort in managing precipitated withdrawal in your patients. It is relatively simple, and we'll dive in. So just a little bit of the landscape. This is probably beaten into most people's heads by now, but this is a huge problem nationally and locally. I think the very latest data shows that overdoses in Michigan have just started to level off finally, and overdoses and deaths have started to level off. However, there is still some disparities in health equity, particularly with Black race. But it's continued to rise since the early 2000s, mostly due to the presence of synthetic opioids, including fentanyl, the pronounced increase in mortality rate. And so this continues to be a problem, and we continue to address it in as many ways as we can. And just a little bit into the acronyms of OUD and why we use acronyms like MOUD. So OUD stands for opioid use disorder. And the reason that we say this instead of other words like addict or abuser is that words matter, and patients stigmatize themselves, nurses stigmatize patients, and doctors stigmatize patients. And number one, number two, and number three barriers to patients being treated for opioid use disorder is stigma. So we can't emphasize enough that this is a major issue that patients address and physicians see as well, and that addiction is a disease, and not unlike any other diseases that we see and treat. We should be treating these patients with medications as we are trained to do. And this is not unlike diabetes. When patients come in with diabetes and their blood sugars are high, we don't scold them or tell them they're a bad person because their blood sugar is high. We give them insulin, and we make sure that they have connection to care when they leave and make sure they can get further medication. And we really need to take this same approach when it comes to all addictions, opioid use disorder, alcohol use disorder. We are equipped to see and treat these patients, and we should do so. And another little acronym kind of explanation is the medications for opioid use disorder, or MOUD, and that's thrown out there pretty regularly now. It's kind of the new terminology. This is essentially taken the place of what is known as MAT, or medication-assisted treatment. And really the emphasis is that the medication itself in many cases can be the treatment, and not everybody needs intensive counseling, and some patients just need the medication. So just because that might be not readily available doesn't mean that you shouldn't be starting patients on medications when you can. So that's a little bit on stigma. I don't feel like I can give any talk about opioid use disorder without kind of harping on it and taking my soapbox moment here. So thank you for indulging me. But fear of precipitated withdrawal is probably right up there behind stigma as one of the reasons why many clinicians don't feel comfortable with starting medications for opioid use disorder. And we'll dive into that a little bit. And hopefully by the end of this, you will feel much more comfortable with the ability to prevent precipitated withdrawal and then also to manage it if it does occur. So a little bit of the pharmacology here. Due to the high affinity for the opioid receptor, buprenorphine can displace other agonists like heroin and methadone that are already present. And it's this lowering effect of the saturation of the mu receptor, which creates withdrawal symptoms. And the sudden and potentially steep drop in saturation of the mu opioid receptors is what causes those unpleasant side effects. So as you can see in the graph on the right, morphine, heroin, methadone are full opioid agonists. And if you give buprenorphine, you will potentially lower their saturation of mu receptors and cause unpleasant symptoms if the presence of those medications is active in their system and it's not been long enough for them to metabolize out. And we'll talk about what the timeframes typically look like there. Additionally, most clinicians, at least that's been practicing for the last 10 to 20 years, have seen tons of precipitated withdrawal, and our early management of opioid overdose was often poorly done, and it was with higher doses of naloxone, which is the pure antagonist. So you may recall seeing patients in the past that got higher doses, 2, 4, 6 milligrams of naloxone, and become very sick because of the lowering from the full agonist of their heroin or other opioid that's caused overdose down to no saturation or antagonist action at the mu receptor. So that those patients that were projectile vomiting and looking very ill, asking to leave immediately, those patients have experienced precipitated withdrawal. So even though it's a feared complication, most clinicians probably have seen it, especially if they've practiced more than 10 years ago. We've gotten better at that. We use much smaller doses of naloxone now when we're reversing patients to try to avoid the patients feeling ill. So to put more simply, this is a nice graph that Dr. Rademacher put together. When you have a full agonist on board, if you give your partial agonist, your buprenorphine, while there's too much full agonist, say heroin on board, then you will cause the lowering, and this is the thumbs down sign here. Whereas if once the full agonists start to wear off, they're going to start to feel natural withdrawal and cravings to use. And this is where the partial agonist comes into play and alleviates the withdrawal symptoms, makes them feel normal, and potentially be able to return to job, school, work, and return as a important family member. So this is the kind of the simplified version of the previous skip graph, and I'll take a minute if Dr. Rademacher wanted to chime in on this one at all, since you did put it together.
Yeah, I think the only addition to this, and I feel like I'm seeing more and more patients who have tapered themselves off of their fentanyl or heroin, and they haven't used in a week, but they have this this chronic desire to use, right? They still have these cravings, and so things aren't going well. And so this graph is really only for the recent administration, or like the last day or two of opioids. And so you don't want to give someone buprenorphine who's had a full agonist recently. And we're going to talk about clinical opioid withdrawal scale in a minute. But if you get way out to the right side of this graph, you may not score highly on a withdrawal calculator, but it doesn't matter because, you know, this line here is way, like, there's no agonist available. And so I just want to reiterate that this is really only, this graph is only pertinent for the first, you know, couple days after they last used opioids. But a week or so out, you know, you can always safely give buprenorphine without worrying about where they are in this graph. So that's the one caveat.
Yep, that's a good point. And, you know, it doesn't, I think With the scale on the bottom here, does that apply to days essentially? 3 days out is about, when you're going to
No,
start feeling withdrawal effects,
I
or is that, yeah, not
I
sure.
didn't. I just put data points because this is all the time course here depends totally on which substance they use. So
Right.
methadone, this line isn't going to cross until 72 hours or greater.
Right.
Whereas for if they have a dependence to illicit hydrocodone or something, it's going to be 12 hours. And so
Yep.
the x-axis is really just uh, indeterminate periods of time.
Gotcha. Yeah, and I think it's probably worth mentioning right now because it is pertinent that your, like you mentioned, your oxycodone or Percocets or even street heroin or even street fentanyl, duration of action is usually at about 12 hours at most, and usually most patients, uh, by and large, by 12 to 24 hours are not at risk for precipitated withdrawal. We do use the clinical opioid withdrawal scale, the cows, to determine that, but the relative time course for most short-acting opioids, including heroin, is about 12 hours. Before the withdrawal symptoms start to kick in, and at 24 hours, they're usually generally feeling not well. The caveat that Dr. Rademacher mentioned, and we'll just mention it now, but go into more detail, is the methadone. So methadone stays in the system much longer half-lives, and you really are at risk to causing precipitated withdrawal if someone's been a known methadone user and you're starting buprenorphine before 3 days since their last use. So 72 hours, 3 days is usually the guideline, and beyond that, you usually want to tell the patient, don't use this until you're feeling sick, like really sick, and not anticipating feeling sick. You actually want to start feeling a little bit sick before you take the medication in order for you to stay in the thumbs up part of this curve as opposed to the thumbs down. All right, and so without further ado, the clinical opioid withdrawal scale, or the COWS scale, is something that we use to help us decide when it's time to start buprenorphine. And I would give the caveat that I almost always ask my patients, are you in withdrawal? And most all of them know that they are, and they know how bad it is. And we generally don't want to start medication until they're feeling mild to moderate withdrawal. And we use the COWS scale to actually determine that level. I always do my COWS scale at bedside. You cannot sit down or you cannot clinically evaluate a patient and then sit down and try to calculate their COWS scale, because there are so many subjective questions in here that you have to ask them physically. Do you have a stuffy nose, for example? That's just not something that you can clinically observe very well. And it's very subjective, and they will tell you. And there's points on here like tremor, for example. A tremor can be felt but not observed. So, if they don't look like they have a tremor, but they tell you they do, or they feel shaky, is usually the way I position the question, then they get a point for that. So usually you need to be at an 8 or higher on the COWS scale in order to start buprenorphine. There are some larger studies, that one of which we're a part of, would suggest that if you're at a COWS of 4 or greater, that it'd be okay to start some of the buprenorphine products. But typically a COWS scale of 8 or higher. And I've seen other institutions, including some of our inpatient algorithms, that say to wait for a COWS of 12. Usually, I think by a COWS of 12, the patient's feeling pretty rotten and are definitely ready for medication. But a lot of the cutoffs are somewhere between 8 to 12. Nick, what do you guys use?
We use 8. I'm generally a big fan of the California Bridge protocols, and they use 8.
Yeah.
This is just one of those things where you're trying to thread a needle. If you wait too long, right? If you, I think, uniformly wait until people have a score of 12, then you are going to lose a percentage of people that just can't tolerate that. And so they're going to go back to using fentanyl. And so it's just like how much of a risk is precipitated withdrawal versus how much of a risk is the continued use of street drugs right now. And I think that 8 kind of threads that needle where we know that at that level, the risk of precipitated withdrawal is very low, but we can retain most patients and give them medications during in ED stay or shortly after discharge. So that's why I like that number.
Yep.
I would really love to see someone do a study where they got rid of the cows altogether and just ask people a yes or no question. Like, are you ready? Are you in withdrawal or not? I have a strong feeling that most patients will know when they are ready for buprenorphine. Um, Honestly, like when I do this, I usually sit down and then just ask, like, is your withdrawal bad or not? And they'll say yes. And I the clinical opioid withdrawal scale is kind of the exact opposite from the pain score that we're used to doing, right? We do 1 to 10, how bad is your pain? Um, because the consequence of the pain score is that the higher their pain number, the more and better drugs they get. And so, the most common number for pain is what? 8, 9, 10, 11, 12. When we just know that they can't be true. But the incentives are that they want to inflate their numbers to get something. Whereas with the clinical opioid withdrawal scale, they know that if they artificially inflate their numbers, then it'll make them sick. And so I usually find that people are pretty honest because they know that they don't want to go into precipitated withdrawal.
Yep, and that's a good point, Nick, that I think is also worth mentioning because I've seen this before. I've seen it happen when I think clinicians are too cautious and they miss that window or that needle hole. And it's to me it's more of a window, but their time is fleeting, and if you let these patients go too far, it's exactly right. You're going to see a gown sitting on the stretcher and no patient, and guess what? They've gone to
Yep.
use, and especially if they came in for treatment that I don't know, quote unquote, grinds my gears. I want to, help these patients, especially when they come in for help. And anytime that happens, it's a total, missed opportunity. And, in my opinion, it's, it's a point of QA probably to, for re-education for the providers involved. But I think that's really important, and I agree with you. I always pair my cows with a "How are you feeling?" and I think that would be an interesting study, like you mentioned. So
Yeah, especially if someone's done an induction before, like, did you feel this sick last time? And they're like, yeah. Like, did it go okay? They say, yeah. I said, do you want it again? And they say yes. Or like the opposite, it's like, I'm not quite sick enough. Like they kind of know.
yep, and I'll give my example. I've caused personally one case of precipitated withdrawal in my career, probably in initiating over 500 patients on BUP. And the case that I had, I think my learning point from it, and I think one of the other things we'll mention is sometimes this is just going to happen. You're going to have precipitated withdrawal, but it's exceedingly rare. It's less than 1% of the time on average. And but the case that I did cause it, the patient was a regular user. She'd been in our ED for 15 hours, and so I knew she most likely hadn't used in the ED, and she was pretty adamant that she hadn't. She was awake and talking to me. It was 3 or 4 in the morning. And lo and behold, she was yawning. She yawned a couple of times while I was talking to her, and so I gave her 2 points for yawning. And she actually, in retrospect, I was more excited to start her on BUP than I think she was, and I might have got her to an 8 faster than she needed to be because she did get pretty sick. And we'll talk about how to manage that when that happens. But so that's another reason. That's like my clinical pearl slash terrible case that I experienced that I hope no others do. That obviously yawning is a nondescript symptom if it's in the middle of the day. But pairing that more with the patient's opinion, I think, is more important than strictly going by the numbers. So. Interesting case, unfortunate for the patient, but good learning opportunity for me and another, um, you know, uh, point for asking the patient how they feel and kind of going with their feeling more so than the number. We as doctors like to, you know, have a tendency to want to treat the number and not the patient. And in this case, and in almost all cases, we really need to treat the patient and not the number. But that said, cows is extremely helpful, especially if you've got limited experience in initiating patients, but always take their perspective into play. So moving on to some pharmacology highlights of bup. We know it's a high affinity partial mu opioid agonist, and it has a long half-life when used to prevent overdose and for cravings. Uh, it's also used for pain, and the analgesic properties are more short-lived. So if you have somebody that's being treated with bup for pain, they're probably getting dosed every 4 to 6 hours. And so if you do have a patient that has both an acute painful condition and withdrawal or has opioid use disorder, that is an option to help control pain just by dosing more frequently. Typically for overdose and cravings, we're dosing twice a day, whereas 4 to 6 times a day would be the timing to dose for somebody that has an acute painful condition that also has opioid use disorder and or withdrawal. The nice thing, the beauty of buprenorphine when used alone is that there isn't a ceiling effect on respiratory perspective, even though it is technically an opioid. We don't have that concern of becoming high or stopping breathing when using the medication. And you can use relatively high doses of it before you even have any concern of that. We commonly give it in combination with naloxone. When you take a sublingual tab of or oral buprenorphine plus naloxone, the buprenorphine is readily bioavailable. However, the naloxone is not. And so there really is no effect of naloxone, despite some anecdotal patient stories that will tell you that they don't want the combined product. I think that the majority of
I lost Jake. Did everyone else lose Jake?
We did.
Okay. Well, let me share my screen and I'll continue. Oh. Jake, are you back?
Oh, I got muted somehow. Sorry. You can
maybe
hear
get
me?
kicked off for a second or something because we lost your screen as well.
Okay. Let me backtrack a little bit.
Okay.
Share screen. Where did you lose me? Can you still hear me?
I can. We were talking about, I think, the naloxone component of
Okay.
the combination product.
Got it. So we were talking about, let's change this up. Talking about the combination of naloxone and buprenorphine, typically used because there is no bioavailability of naloxone when taken orally or sublingually, as opposed to if you were to take a buprenorphine tablet or film and inject it, you will be injecting naloxone, which will cause opioid antagonism and no high whatsoever, essentially like giving yourself Narcan. So that's the reason why we use that medication, and it's really well tolerated typically by patients, and for a lot of different reasons, one of the best medications for opioid use disorder. You can give a prescription for it. The other major option in the opioid class would be methadone, and that typically is a medication that needs to be taken daily at a methadone treatment clinic, and you need to go there. It's not really conducive for holding a job or getting kids to school or whatever else might be life's challenges. So, any other comments on bup?
Yeah.
Anything I might have left off here, Nick?
Yeah. The only caveat is that you'd mentioned that if you would, you boil down your strips or tablets of buprenorphine and naloxone and inject it, you'll get a naloxone-like reaction. And I think that's true for some. For others, what you really just get is minimal effect of the buprenorphine because the naloxone competes at the receptor with the buprenorphine. If you were to inject pure buprenorphine at this dose, it certainly could cause some respiratory depression and euphoria and could be a source of abuse. And so the combination with the naloxone is very important. And so we should really be, focused on prescribing the combination formulations basically at all times.
Yeah, and this, and as far as I know, and this is somewhat anecdotal, this has street value, and patients can potentially divert it. So if they are going to divert, we want them to divert the combined product because of the less abuse potential and less likely to be diverted.
And on that, almost all diversion for buprenorphine is for under treatment. And so if there isn't easy access to treatment to get your own prescription, then there's street value because of that. It is rarely diverted for euphoric and misuse. And so I think that's another concern that some people have, that they shouldn't.
Right. In some ways, when my patient comes in and tells me they've taken some from the street, that is like, I see that as a good sign. Is they're ready for change. They understand that they've got experience with the medication. They know it's not necessarily going to make them sick, and they're willing to start treatment and already have some experience with it. So it's not necessarily a bad thing when you do see that, which is relatively rare. So getting back to the management of precipitated withdrawal, and we can talk about my case, but in all cases of precipitated withdrawal, the treatment is the same. Essentially, you want to give more buprenorphine. And I think that since I put this slide together, I think Nick and I's recommendations actually might change, that we might even want to go higher for the additional buprenorphine, maybe even 16 milligrams, depending on what the patient's substance use history is. Whether it's fentanyl or heroin or other pills, you can give 8 milligrams every 8 milligrams of buprenorphine product every 30 to 60 minutes, up to a total dose of 32 milligrams is usually the recommendation. When you're doing that, you can also be giving your ancillary medications. You can give clonidine, you can give your ketorolac, ondansetron, methocarbamol, Robaxin for muscle aches, and IV fluids. And bottom line, when you do see this, the patients look bad. They generally do fine. You have to kind of coach them through that. And one of the hardest things to do is to talk to a patient that just took buprenorphine from you and tell them, I know that just made you sick, but you have to trust me. I'm going to have to give you more of this to make you feel better. And it's a difficult conversation, but at the same time, they generally are receptive because they feel so bad. They just want to take whatever they can to feel better. And I find that IV fluids, and turning the lights off at some point when you get them more comfortable on a 12 to 24 hour nap is generally what they need. I'll just go into the next slide here, and Nick, you can chime in too if you'd like. But this is actually, I believe, a California Bridge protocol for buprenorphine precipitated withdrawal. And this does have the 16 milligram recommendation right off the bat, and potentially giving, if they're not actively vomiting, a benzodiazepine. So if you're pretty convinced that your patient went from feeling okay to actively sick within an hour or two of you giving them buprenorphine, then you may have to give them a benzo, even though it's not highly desirable to be adding benzos with buprenorphine at the same time. You may have to, put them in a monitored situation with your CO2 monitor, entitled CO2, as if you were treating an overdose, just for safety purposes. And if they're not better after the initial 16, you would get them with another 16 up to 30 minutes. And if at that point, if they feel better, they can be watched for a little while and be discharged with their prescription. But you can give the benzos, you can give antipsychotics like Zyprexa, olanzapine is listed there, clonidine, like we mentioned, pramipexole. I've never used it before. I've never seen it before, but it is a dopamine agonist. And the Lyrica or pregabalin is another medication that can help with some of the symptoms of withdrawal. I have not used this before, but in my one case of my patient that felt really bad, I would potentially try some subdissociative ketamine, and that is part of the recommendations on this algorithm. And then if that's not working, you can give fentanyl, which kind of talks about or speaks to how you would treat uncontrolled acute pain essentially in the setting of a lot of buprenorphine. So if you have a known patient that uses buprenorphine for opioid use disorder and they have an acutely painful condition that you're unable to control, the way to overcome the buprenorphine is high dose fentanyl in doses that you probably would feel very uncomfortable to give any other patient, because that fentanyl is competing with the high affinity buprenorphine trying to get to the mu receptors. And you may need to use, this says here 2 milligrams of fentanyl, so big doses in total. So, and then you would treat the patient once you get them feeling better, just like you would. They should not have further reaction to buprenorphine, so you're going to definitely want to send them out on buprenorphine or a long-acting product if it's available at your facility. And I'll pause there for Nick to chime in. And
I think these are nice, simple slides. I think when looking at these over and over, it makes as much sense to me to say that there's a cap of 32 milligrams of buprenorphine as it does to say there's a cap of 100 milligrams of propofol for a shoulder reduction. You kind of have to use these doses looking at the patient, looking at their vital signs. We're in the emergency department, right? These are not recommendations for an outpatient setting or even the floor. But if you were to get someone who's sick, I would basically transition this to a constipation type of situation where you're going to get your respiratory therapist there. You're going to put them on a monitor, and you're going to give them as much medications as needed to make them comfortable. Because remember, people with ongoing opioid use disorder who have suffered an overdose, which is going to be anyone who uses for any period of time, given the fentanyl in the system and like the drug supply, the mortality rate is 5%. And so I think we just have to be willing that, less than 1% of the time, we may have to transition from something that's very simple to a patient that becomes sick because they are sick. They have a really, bad disease. And so being ready to care for these people if they happen to get sicker, I think is something that's totally within our realm of emergency medicine. We should be comfortable just as if we're doing a hip reduction, shoulder reduction. But I think arbitrary caps on doses and making the patient suffer is not the right way to go.
I think that's a good point, Nick. And, looking back to the case that I had as well, that person was very sick. They were vomiting and having an active bowel movement at the same time. So not only was I not her favorite person, I was not the nurse's favorite person either. And so, both in the patient's interest and the level of nursing that somebody might need for, actively, not feeling well, to put it mildly. You want to be more aggressive. And in the case I was, pushing with, I think I gave her another 24 milligrams of bup plus the other ancillary medications. But I probably should have went to ketamine, and or like you are saying, go big, stop the symptoms essentially, and watch them for a few hours, and they're gonna feel better. It's just that acute presentation when you see it. It suits you, the patient, and nurses the best to get on top of it as soon as possible. And I'm gonna stop sharing, Nick, and I will turn over to you, and I will chime in as needed.
Yeah, we're gonna move to some cases. I feel like Zoom is updated since the last time I did this. Share screen. Is it in the meeting?
You hit share screen, and then you should ask you to pick a screen.
I see share screen now.
Yeah.
Got it. Sorry about that.
And I guess we could use this minute. We do have an attendee live here. So Beth, if you had any questions, we would be happy to address anything you have before we get into cases. But if not, no worries.
Okay. All right, so case number one, we have a young man who was brought in by EMS after being found unresponsive with really a decreased respiratory rate of 6. Around him was drug paraphernalia. I think everyone's thought was that this was an overdose. He had pinpoint pupils suggesting an opioid was the cause. The paramedics then gave 2 milligrams of intramuscular naloxone and put the patient on a stretcher and put in the ambulance. And then during this transport time, they gave 2 additional doses of 2 milligrams of intramuscular naloxone, so a total of 6 milligrams. When you see them, the patient is awake, anxious, agitated. He's thrown up on his shirt and smells as if he had a bowel movement as well. And he wants to leave immediately. So I think this is probably a situation that, we've seen, unfortunately. And as you mentioned, it happened a lot more, 5-10 years ago than it does now. But I think, prior practice was that if someone was obtunded, you try a dose of Narcan to wake them up, when really the indication for Narcan is decreased respiratory rate. So I think this patient did need naloxone. The question is, do they need 6 milligrams or would a smaller dose have been better? And then what to do after you do make them sick. So Jake, do you want to chime in on this case? Give me your thoughts.
Yeah, no, I think even though we're looking at a case here of the person clearly getting intranasal by the picture here, this is, like I said, pretty common. I think there is some delayed effect of naloxone, and so I think the appropriate dose probably, obviously, if they had intranasal product, I think it's better or easier to administer. But giving the initial 2 milligrams of IM, and then in the ED, if this was the case and they weren't breathing, we would be bagging them. We would bag mask valve, and do some ventilation for them. And then a course of 2-3 minutes, they probably will start waking up. And, depending on the level of training of EMS, they give somebody a medication if they're not acutely, improved within a minute or two, especially with an IM product. And I could see why they would do that. This is you still might see this, I would say, but I think now with the intranasal product, what's interesting here is I think this is what most EMS give. Not a lot of them have the Narcan, trade name Narcan sprays. I was talking to my pharmacist, and apparently these kind of atomized versions it's a significant amount of fluid. So it's like 2 milligram or 2 mLs of fluid that get atomized, and not all of that's going to get absorbed. And so they're getting a lot smaller doses now than they used to when you give IM. I saw there was a comment, but I can't see it now.
Oh, so Beth makes a comment that she works in PHP Region 4. So great, happy to have you. And their staff makes SUDs treatment referrals. It's good for me to know this because happening at some of the EDs now, because historically what we would hear from callers seeking treatment is the stigmatization services received when going to the ED in the past. Appreciate the work you're doing. Thank you. I think we're trying to make an improvement. I think we've made a lot of inroads with a lot of the emergency departments. I would not say that what we're advocating for is probably standard or common in every site. And so there'll be a handful of hospitals that are really in tune with this, and majority are still making progress. If you're in Region 4, I'm not actually sure which counties that is, but I would probably talk to the medical directors at those hospitals, and maybe you can develop a preference for which hospital you send them to, because not everyone is going to be the same. So I think the other part of this case, we have a whole discussion about how to do naloxone. In general, in the emergency department, you want to give smaller doses, give it time, see if they wake up, they're breathing. Now, if someone looks like dead, I don't mind, give them 2, again, this is a risk reward thing where the risk of respirations of 0 is much higher than the precipitated withdrawal you might cause. And so fine, like bring them back and put them in precipitated withdrawal. But if the respiratory rate's 7 and you want it above 10 and they don't look terrible, then give them 0.04, 0.4 milligrams until they wake up. So that's one component to this. The other component is, well, what do you do once they're in withdrawal? Because again, the calculation is much different. If your EMS or your emergency department is going to be quickly giving buprenorphine to people who come in with naloxone precipitated withdrawal, then you can overshoot a little bit with the naloxone because, again, the downside of letting someone be obtunded and not breathing from opioids is also bad. So it's both the treatment and then what's your backup really determines how you should manage these patients. Okay, our second case is a 44-year-old man who came in to the emergency department feeling sick 30 minutes after taking a 8 and 2 milligram dose of buprenorphine naloxone. So that for those that aren't accustomed, 8 and 2 simply means 8 milligrams of buprenorphine. The 2 milligrams is the naloxone component. The patient is experiencing diffuse muscle aches, anxiety, abdominal cramps, and a runny nose. He states that he used heroin at 5 p.m. He did not want to experience withdrawal in the middle of the night, so he took the buprenorphine and naloxone combination at 11 p.m., which is 6 hours later. And then soon after he took it, began to feel sick. So I think, seems like a pretty common case of self-administered buprenorphine with precipitated withdrawal. I've seen a handful of these as well. One of the worst consequences of this is that many times when I've tried to give people buprenorphine, they'll say, I'm not doing that. Last time I took it, I got sick. And if you dig deeper, it'll be situations like this where they took it too soon after they last used opioids, and then they go on assuming that buprenorphine either is an allergy to them or that they can't take it. It makes them sick every time. They'll tell you that the naloxone component made them sick. But in reality, what's happening is that they're giving themselves buprenorphine before they're in sufficient withdrawal. They're in that part of the curve in which the full agonist is active, brings them down to the partial agonist. They come in because they're sick.
I would add in there that I've definitely seen that too, and I try to have longer conversations with those patients and delve into it. And some of them will swear, no, it had been 2 or 3 days since I used, and they tend to be fentanyl users, like heavy fentanyl users, like known fentanyl users. Almost everybody is using fentanyl, even though they might not know it. In those cases, I say, well, when you've been treated in the past, you probably just didn't get enough, and there is some toxicological rationale that, those that use fentanyl regularly might be sequestering it in their tissues for longer. And so therefore it might be hanging around for longer. And so if they do feel a little bit sick after taking medication, even if it's only been a couple of, if it's already been a couple of days, like if their histories are accurate, then I would say, well, you need more. You need 16, or you need 16 right off the bat. And like I said, that is really more popular theory in toxicological circles, and we do work with renowned toxicologist, Dr. Andy King, and I have Dr. Yakey with me at Henry Ford as well, who works for the Michigan Poison Center. And I have seen him be more aggressive when there's known fentanyl use, and I've seen very good outcomes. So he does like to go to 16 right off the bat when he knows it's fentanyl, which is pretty reasonable. And like I said, patients do pretty well. So that conversation that I tried to have with the patient that tells me it made him feel sick, the next step in that is that, well, you probably didn't get enough, and that's why you were, still feeling ill.
Yeah.
I think there's another comment here we should probably address. So, so Southwest Michigan, Kalamazoo, that's actually one of our counterparts. Dr. Maureen Ford is out there, and she's one of our consultants as well. So, and she's been really active in that area and starting to implement protocols. So she's a great resource, and we'd be happy to connect you. The next comment is what is happening in the EDs following BUP induction for continuation of care. I'd be curious if you have heard of Boulder Care's Quick Start approach and your thoughts on that. Maybe not a question for this webinar. I think it's totally reasonable to address that. I've not heard of Boulder Care's Quick Start, but you might be interested in hearing our talk next week on ED-MOUD implementation. That'll be on the 13th, and we're going to go in depth on putting your protocol in place, but a huge part of that is establishing your outpatient referral network. So as you know, the PIHPs have a lot of the funding for these organizations. And so generally you're connecting with PIHP to get the names of places you're referring to. And then ideally you're able to refer in real time. So you get the actual warm handoff, patient knows where they're going, what time, and transportation has been addressed before they even leave the ED.
Yes, and I'm I'm not familiar with Quick Start with Boulder. I've been using the California Bridge Quick Start typically. We'll bring it up maybe at the end of the presentation. We can share a screen and kind of look and see how they're recommending. The truth is that there's a lot of different methods. And so, yeah, we'll bring those up and kind of talk about the pros and cons of what they're doing at the end, if that sounds okay. Oh, okay. We'll click the link in a little bit. Okay. Case 3. This is a 56-year-old woman who comes in with nausea, vomiting, cramping, body aches, runny nose. She has a known history of opioid use disorder and been taking methadone for 2 years. 6 days ago, she used heroin and overdose, which resulted in an ED visit. After being discharged, she was referred to an outpatient clinic where she was given a prescription for buprenorphine and naloxone. She was advised not to take the prescription until at least 3 days after her last dose of methadone. She was afraid she was going to go into withdrawal and did not want to experience that. So she took a film, a full dose, 8 milligrams, 2 milligram combination, a little more than 2 days after her last dose of methadone, and thereafter felt ill. So naloxone precipitated withdrawal, buprenorphine precipitated withdrawal in patients with on methadone is challenging and can happen. And it's often happens just like this, where someone hasn't waited the sufficient amount of time. Methadone is a little bit like fentanyl in that bioavailability varies greatly between patients. Metabolism rates, lipid solubility is just hugely variable. And while some people would be fine to take buprenorphine after 2 days, some people after 7 days might still precipitate withdrawal. And so it is a more challenging medication. I'm going to bring up some protocols in just a second that can show how addiction specialists do this. But I think the main point I want to state here is that if someone is on methadone and has taken it probably within the past week or so, the safest thing to do is to have them continue their methadone until they can follow up in the addiction clinic, and then they can talk about the options that you have, because it's really not straightforward. And so these are just patients that we probably should not follow our ED-based protocols for simple inductions on.
Yeah, one thing that I find interesting about methadone, I think it's a interesting medication. It works really well for some people, and I think it's for the average person that, like I said, has a job and a family, it's not a great choice due to the need to go to the clinic daily to get your medication administered. However, there are certain indications for it. What's interesting to me about it, and I hope I'm not stigmatizing the patient population by saying this, but that you can use an opioid agonist while taking methadone without feeling sick. And I feel like in some patients, and you could also argue that it's harm reduction, that they're not willing to go on bupe, but they will go on methadone. And so at the very least, they're not using as much probably if they're taking their methadone regularly, but it does not stop them from having an overdose on heroin or another opioid. So it's just like an interesting caveat of methadone itself.
I think that's true. They do, while it doesn't stop it, they do have fewer overdoses, right? So like, that is important to say that it is very helpful, even though it doesn't have the antagonist effects like buprenorphine does. And so I agree. I think my initial choice for almost everyone would be buprenorphine. And then if it doesn't work, then a higher level of care is the closely monitored methadone settings. I don't know. Some people just have such severe opioid use disorder that they're probably not going to hold down a job and like take great care of their kids anyways. And so if you can at least make them safe and start getting things back to normal, like I think that's the first step. Interestingly, I had someone this week who'd been on methadone for years, so long, and been doing so well that he, on every Monday, would go to the methadone clinic, check in with his counselors and his team, and get a full week of take-home doses. I think that's the longest amount of take-home doses I've ever seen anyone have. But so there are options, but it is certainly a more resource-intensive setting, which is appropriate for some people. But I do think that more people could be safely on buprenorphine than we currently have between the two options. All right, I think we talked about most of these key points. I think Jake had illuminated a lot of these with some papers as well. And so these are mostly academic centers that are doing this, but there are pre-hospital EMS systems that are giving buprenorphine to patients either initially, like if they just want it, or if they give them naloxone for rescue and then result in withdrawal. And so, if a medic in the field can do this, I certainly think that we can do this in a high resource intensity emergency department. And these patients did really well. I reviewed these studies before we started today, and it was mostly cases, but patients that get buprenorphine by itself or after naloxone basically they have equivalent rates of follow-up to their 3-month appointment as those patients that come into the emergency department without receiving buprenorphine in the field. And so that's actually surprising to me, because I would have suspected if someone didn't seek the care, right, if they overdosed in the field, that they would follow up less certainly than someone who came to the emergency department seeking care because they were like at a pre-contemplative phase of their care, but it seems to be the same. And so maybe what we're doing is pushing them into treatment when they actually weren't ready. And it doesn't seem to matter because they're still in care between 30 to 50% of the time at 3 months, just like everyone else.
Yeah, what I found interesting about those studies too is that I think their protocols were generally to bring patients in, but if they gave them naloxone and then the patient refused transport, which is not uncommon, that then they would offer this higher dose bup in the field, and the effects of that when you're loading that person up with so much bup is that they are almost protected from a overdose in the next 24 to 48 hours because their mu receptors are saturated, and also they actually don't feel bad, so they don't go back into that craving or withdrawal phase. So it actually gives them a minute to take a deep breath and maybe make that appointment that they were referred to. So I think that that's possibly why that phenomenon is occurring, and it also kind of underscores how to treat bup, loading up with high doses in the cases that you're seeing withdrawal after medication, whether it be naloxone or buprenorphine.
Yep. So case 2, I think, they took their buprenorphine much too soon, caused withdrawal. And so in general, you want 12 hours for short-acting agents and much longer for things like methadone. Any OxyContin, for example, would be longer. And then fentanyl is a wild card that we'll talk here in a slide or two, just because the lipid solubility makes it a variable for every patient. And then methadone case, at least 72 hours since methadone, but for some patients longer. It can be helpful if you get a drug test, because if they're still positive in the urine, it's probably going to, precipitate withdrawal, but I'm not sure how, helpful it is in reality. And then, yeah, in general, it's kind of like most withdrawal. They should be in moderate to severe withdrawal before they start, because that's more suggestive that the methadone has left the system. So if you're waiting 72 hours and they're not feeling sick yet, then you're probably going to get sick if you get buprenorphine. Whereas if you wait 72 hours and you feel quite ill, buprenorphine is more likely to be helpful than harmful. It's important to remember that buprenorphine does bind to that receptor 15 times greater than methadone. And so any methadone you have left on the receptor is just going to get bumped, and you're going to go from that full antagonism down to the partial.
I would add one thing there,
Yeah.
Nick, and I put this in, and I almost regret putting it in, about if you're uncertain if a person has been taking methadone, to get a urine drug screen. And the problem is it can be positive for up to 2 weeks, so it's almost like not helpful. And I can't think of a case where a patient is unsure if they took methadone or not. Like, they usually know the supply of it's really limited. And so, and patients are typically willing to report, what they're taking when it comes to methadone. So this might give people, if you're quote unquote not sure, right? Like, a lot of times we don't know what a person took when they've overdosed. But when they are awake again and starting to experience withdrawal, I think that's the time to ask about the methadone use. And, if they're adamant that they do not take it, then I think you're safe. If they're unsure, I guess you can rule it out with a UDS. But if it's positive, the time course is not that helpful. And so another kind of follow up to that is for this larger study that we're using an injectable form of Bup for. I've actually, a contraindication is a positive methadone urine test. And I've had patients that had gotten buprenorphine in the ED before their methadone urine screen had come back, which is part of our study. So like, the treating team just gave a dose, and then we enrolled them in our study and found out that their methadone was positive. It's usually like they've used it in the last 5 to 7 days. And so we went ahead and enrolled the patients in our study, even though their methadone was positive, because I know they just took Bup and they felt fine and they felt better. So they're not really at risk for that precipitated withdrawal in that case.
Yeah, this is another one where incentives help you, right? I kind of leave have you used any heroin or methadone recently? And they say no. I say, okay, because if you have, you're going to get really sick when I give you this medicine. And like, they don't want to get sick. So they know they're going to get found out. And so it's one where just people don't try to trick you, because they know the consequences are on them. So the big question, I think, with precipitated withdrawal is there's been a lot of conversation about what has fentanyl in the drug supply meant for precipitated withdrawal, because there is, I think, a lot of anecdotes that patients are more likely to suffer withdrawal if they've been using fentanyl heavily. The truth, and the reason is that fentanyl is highly lipophilic, has this reservoir effect, kind of like THC, I think, where you'll have like a slow, basically infusion of the chemical into your blood supply, because it's being released from the fat for an unknown period of time. It just can take a long time, and the consequence is that if you have fentanyl active for much longer than you would expect, the buprenorphine has a high affinity compared to the fentanyl. It bumps it off 6 times fold higher. And so you go from that full agonist of fentanyl down to buprenorphine, and you get sick. That's kind of the pharmacologic theory behind it. I think the truth is more muted, and that Jake and I have been doing this for 4 or 5 years now. I haven't had any precipitated withdrawal. The truth is anyone who's using, street opioids at this point is using fentanyl. At least a majority of the time, maybe not every time, but most of the time there's fentanyl in their drug supply. And so to try to single out who is using fentanyl, who's not, it all has fentanyl in it. Even the pills that people think are actually narcos or hydrocodone it's still fentanyl. That's just what people are pressing into pills now. And so given that we've had this experience for this long and really don't see that much precipitated withdrawal, I think it speaks volumes. When I review these cases, the truth is I think what's happening is that people are nervous and they're just using too small doses of buprenorphine. You see these cases a lot when they start them with 2 or 4 milligrams, and then it's insufficient dosing. They either continue to feel sick or that moves a little bit of fentanyl off the receptor, but not enough buprenorphine to activate the receptor. And so I think the most evidence suggests that either just initial high doses of buprenorphine is the right way to go, or that the fentanyl risk for precipitated withdrawal is not as severe as what was, I think, talked about a year or two ago. Do you want to kind of highlight your ED innovation study? Because I did a little research on it this morning. It looks like it's still in process, so there's not much
This
out
is
there.
finally about to wrap up. We're close to the 2,000 patient goal, and I believe we published a study, or at least a commentary on what we'd seen after 1,200 patients, and at that point the precipitated withdrawal rate was as known to be 0.5 to 0.7, something like that. So less than 1 in 100, more like a couple in 1,000. And now that we're up to almost our goal, despite the fact that 80% of the enrolled patients who have that they provide urine sample for us, obviously, that test positive for fentanyl. I would say anecdotally, at least at Henry Ford, only 10 to 15% of patients are knowingly taking fentanyl. So underscores the point, fentanyl is everywhere, and despite all that, the presence of fentanyl, we've had less than a 1% rate of precipitated withdrawal, so less than 15 total cases out of 1,900 patients. And I've seen a couple of cases where you're like, is this precipitated withdrawal or not? And usually it's somebody comes in with a COWS of 15, 18, 20, so they're already in pretty moderate to severe withdrawal, and they just don't get better fast enough for you. And that's not precipitated withdrawal. That's difficult withdrawal to treat and might require more other medications. That could be polysubstance, it could be partially a cocaine crash or alcohol withdrawal as well. So there are cases I've seen that in retrospect I know are not precipitated withdrawal, and more like just a difficult patient to treat, as opposed to or difficult withdrawal to treat, as opposed to true precipitated withdrawal, when you have somebody that's feeling relatively okay and then all of a sudden they're vomiting and having bowel movements on themselves.
Yeah, I was just going to comment. I think any measurement of precipitated withdrawal in these studies is going to be conservative, because they don't want to undercount, but they're almost certainly overcounting, because I have seen difficult to control withdrawal. And quite frankly, I've seen a lot of patients that you warn them about precipitated withdrawal. You talk to them about what's going to happen if they take the medication too early, and then they basically have a panic attack in the setting of this. And so the anxiety component is severe at times as well. But do they have the full nausea, pooping on the floor, tearing? That is pretty uncommon. But I do think difficult to control withdrawal and anxiety around the time of a new medication. And we see this in the emergency department all the time, right? How many times do patients report allergic reactions to medications that you give them, or dystonic reactions to Reglan or something like that? And the truth is that they don't have any rash, they don't have any symptoms of actual medication administration. It's panic and anxiety around the possibility of a reaction that kind of feeds into it. So I think that happens for almost all medications, including buprenorphine. I do have a couple. Let's do this. We'll conclude. We'll look at the Boulder protocol real quick and talk about that with Beth. And then I have a couple other articles I wanted to highlight that do show how you can do like a low dose initiation of buprenorphine. This is always, I think those protocols are best done in the hospital setting. They take days, or in the outpatient setting, take days to weeks to do, and are really not ED appropriate. but knowing about it is helpful. And then I want to show a couple of schematics about how it actually goes when someone has precipitated withdrawal as well. So we think this withdrawal is very rare. We said less than 5%. I think it's way less than 5%. In general, waiting 12 hours after the last short-acting opioid.
That's got to be a typo.
Oh, 0.5%.
Yeah.
Yeah. Typically need to wait 12 hours after a short-acting opioid. Be very careful with methadone. It's really tricky. And then it happens, you can do adjuncts as necessary. And if someone gets really sick, treat it like a critical care situation. They have a critical illness with opioid use disorder, 5% mortality per year. And so sometimes every once in a while, you'll have to step it up and make it like a consultation situation. And so I think that also funnels into the idea that it's a severe disease. And so we should be ready to act severely if needed. So let me click on this link so we can take a look and see what the Boulder people are doing. Now, can you see my internet screen, or am I just sharing my PowerPoint?
Just the PowerPoint still.
Okay, so then I'm going to switch to the internet screen. All right, so we're just going to do this off the cuff. So naloxone accelerated complete transition methadone just for starting buprenorphine. So webinar, this is great. It's very nice. Methods. Okay. So they talk about, so people have these microdose, low dose, high dose. I think microdose is, something that probably it's like an addiction medicine specialization. Low dose and high dose things are done in different emergency departments. And they're activating, or they're advocating for the START, which basically says if someone's used, they can be started on buprenorphine. Takes 30 minutes, no tapering, withdrawal 30 minutes, and the whole transition takes an hour. It uses naloxone to clear opioid receptors. And so basically what they're doing is they're precipitating withdrawal with naloxone as if you would do it in the field, and then starting the buprenorphine right away. We just did some cases about how we do that. I think patients would have to be totally informed and that they're going to feel sick for a short period of time and willing to then get the buprenorphine soon after. I don't know. I think it's a novel approach. I don't have a lot of I think there's probably a little downside to it. I don't think it's the norm right now, but it could be in the future, but it certainly would work. Jake, do you have any thoughts at first glance?
Yeah, I don't see much difference between giving. I personally probably would rather just give the bupe, because if there is going to be any, withdrawal effect, then you might as well cause it with bupe, and then maybe the bupe will just take care of any withdrawal as opposed to giving somebody naloxone. That would be my. I don't know. I know the people that are out in Colorado are pretty much pioneers in this. I think Don Stater is one of the ACEP guys that puts out a lot of good information on opioid material. So I'd like to talk to him about it or listen to what they have
to. Just a home induction. Beth, that's what, for people that aren't ready, they're not in withdrawal yet, I just give them an option, and when they're ready, they take it at home. And so I think that the quick start is a new idea. Maybe some situations it would be good. Maybe if you're going to jail or something where you can't really do a home induction, then maybe that's the way to go. But for someone that's being discharged, I'll just give them a prescription. Let me bring up this paper real quick. So here, This is a protocol that's published about how to do a transition from methadone to buprenorphine. And so these people, they use these transdermal patches. And so for 3 days, they take their normal methadone and then they put a patch on. Day 4, they put a second patch on. They do that for 3 more days. They start to titrate up the doses of the patches with the methadone in place. And then they get rid of the patches after 3 weeks. And then they start doing sublingual buprenorphine. So what I'm trying to say is that this micro and low dose stuff is awesome in the right setting. This is not an emergency department or something that an emergency physician should be doing, but there are options out there. So in general, if someone's on methadone and doing okay, but wants to transition to buprenorphine, probably not a place for an emergency physician to step in and do that. Refer them to the addiction clinic. Hopefully you have a specialist locally who can do something like this, where over 4 weeks is going to transition them. That describes case series of patients that were thought to have precipitated withdrawal. And they're actually quite choosy. I think they had 13 patients in this cohort, and they selected that most of them actually just had difficult to treat withdrawal and not precipitated withdrawal. But for the ones that were thought to actually have precipitated withdrawal, they show here the time course and the interventions for the patients. And so if, for example, this patient was given buprenorphine at time 0, and then within 10 minutes or so, the cows started to go up into the 20s. These X marks are when buprenorphine was given, additional buprenorphine was given. And so you can see, like, they could tell almost right away that this person was starting to get sick. And so they gave 8 milligrams, 8 milligrams, 8 milligrams, 8 milligrams, 8 milligrams within, 180 minutes. So within 3 hours, this person got a lot of buprenorphine. And then you can see here what started to happen is that cows went back down and he got discharged. So this is a pretty typical pattern here. Someone gets the buprenorphine, they start to get sick, and it goes up, and then it goes back down, right? And they're discharged. And so sick, get an extra dose of buprenorphine, and goes back down. This one had a bimodal phase to it, started to get worse again. They get another dose, but this time they got 32, I can't see it, 16 milligrams. And then boom, cow's score goes down. And so I think this person down here left AMA. But so the point is, it happens, people treat buprenorphine, they get better, they get discharged on buprenorphine. So that's kind of what I wanted to highlight with these little accessory papers that I didn't initially include in the presentation. All right. I have one more chat. Oh, Beth emailed us the info for the people in California, I believe. Great. All right. So, this is a 2-hour session. We leave a lot of time for discussion. Is there anything else that anyone wants to talk about? Okay. Well, I think if I've added a couple of things, I don't have a lot more to add, so I think we'll probably end early. Naomi and Clarence, do you have any additional thoughts?
I don't have anything. I think just a reminder that this is recorded, and the recording will be placed on CFSEM's webpage after today's session.
Great.
Yep. Thank you to our guest for attending. I enjoy talking about this stuff with you, Nick. So I always like to hear, we feel like we know things, but it's always good to hear from other clinicians. So I actually enjoy this format, and hopefully others will take, some good information from this as well. And I think the bottom line is, precipitated withdrawal is exceedingly rare, and it's, although it can be dramatic, relatively easy to treat. There's no, and I actually like your additional thoughts about treating it as an emergent condition, with a critical care approach that we're all trained to administer, like we are fully capable. And I'd almost be interested in developing more on that, or if there's more out there about how, like you said, this is a high mortality condition and probably needs, just like sepsis or trauma, we mobilize a lot of resources in short order when it happens, and we don't want these patients leaving AMA because we made them sick. That would be the worst case, and probably I don't even know what their mortality would be after that, but they'd probably be even less likely to come back to the hospital or seek treatment. So we might be making their mortality worse if we're not being aggressive in the treatment.
Yeah, I think all of these considerations have to be, thought of in context of those first graphs you showed, which was the mortality rate and national epidemic of opioid overdose deaths. Think of the medications we give that can cause side effects. Beta blockers, TNK, any anticoagulation. We see, bleeding in the brain, internal bleeding, GI bleeding, all these consequences because we're trying to prevent strokes or consequences of stroke, dysrhythmias, all these other problems that can occur that are bad. And I'm not saying we certainly should be treating people with medications to prevent these things, but it would be really too bad if anyone was afraid of precipitated withdrawal and therefore didn't pursue treatment with buprenorphine in the emergency department, or didn't do it as a clinician because of this fear of a side effect, when we kind of navigate, pros and cons and side effects and treatment benefit all the time.
Yep, well said.
All right. Hope you have a good day.